Okay, everyone's coming back in. Right, so let's have a little think about this corneal dystrophy. Everyone hopefully spotted it was a corneal dystrophy.
That was a neat case.
Yeah. Okay. So some comments from people. What did you think?
We thought it was pretty superficial, subepithelial, loss of Bowman's, but we couldn't see basement membrane type dystrophy. And then we realized there were a few different diagnoses that we couldn't differentiate between.
Let's have a look at the thing. Have a look at the cornea, and then we'll have a look at the textbook. We thought it was hyaline material from the comment, and of course we don't have any stains on this, so we'll talk about the stains in a minute. Right, let's have a look at this. Let's go to the slide. Hopefully that's it, and share screen. Okay, so looking at this at low power, this is a someone who's had a corneal transplant. We can see here we've got a bit of epithelial downgrowth into the corneal transplant. So this is maybe not even the first transplant, because we've got stuff happening out here as well. So we've got Bowman's membrane kind of curling around and quite a complicated scar, and then a bit of epithelial downgrowth through here. The epithelium's normal, and there are deposits here superficially in the cornea along the basement membrane through here. So the deposits aren't continuous, they are quite separate to one another. And we notice that Bowman's is gone, which either means previous ulceration or it's part of the problem. And some of the deposits do actually seem to be above the basement membrane and heading into the epithelium, though this one could well be below it. So we've got, and there's nothing, the corneal clefting looks normal and Dismays looks normal. So we haven't got any stains, but we've got this discontinuous, predominantly subepithelial deposition of brightly eosinophilic material that is got no particular consistency. It's hyaline in texture. And then we've got to try and work out what it is. So it's, let's have a look at the textbook. Let's just switch screens here and go to the AAO book. We can immediately rule out some stuff. So it's not an endothelial dystrophy, she says. Okay, let's have a look through some of the other things. It's probably an epithelial stromal dystrophy or an epithelial subepithelial dystrophy, because it's carefully positioned like that. So let's consider what we've got. Epithelial basement membrane dystrophy.
I like the look of that.
We couldn't see any of the curly basement membranes present, could we? So not that. So we're into the epithelial stromal, TGFB1. I used to like it when they called it a big H3 because that was easier to remember and say. So the first one is Reese-Buckler's. So Reese-Buckler's is a good possibility. It generally tends to have this uniform distribution rather than a lumpy distribution.
Discontinuous, wasn't it?
Yeah, ours was pretty discontinuous rather than that. Yeah, the Reese-Buckler's would stain bright red with Masson's trichrome, and this is this picture here. Okay. So we're considering that maybe it's an atypical presentation of Reese-Buckler's with lumps everywhere. Okay.
And it's clearly something that recurs because this is the second transplant they've had at least.
It is the second transplant that they've had at least, yeah.
clue, hasn't it?
This one here, so we don't have Theo Bencase because we don't have this irregular kind of wavy line that we get. So I don't think it's that. It's definitely something that's depositing. Lattice, so it's not in the middle, but it could possibly be lattice with an atypical distribution. We would know by doing a Congo red or asking the clinician. Granular type 1. It could be granular type 1. We've got an abnormal deposition, a discrete deposition here. And this also stains bright pink with Masson's trichrome.
Like rock candy.
Could it be granular type 2, previously known as Avellino? Yes, possibly. But I think that we will be able to sort that out with a Masson's and look for amyloid. That's often possible for amyloid. And I don't think it's macular because we don't have deep stuff here. So we've really got a differential diagnosis in the common ones between granular dystrophy, type 1 or type 2, or between Reese-Bucklers. So at this point, staying with Masson's trichrome wouldn't necessarily be helpful. And even the crystalloids that we'd see on EM would resemble each other. So what we have to do is we have to look at, well, actually, why don't we apply our clinical knowledge for a bit here? I'll stop sharing. Okay, so you guys, if you think of your clinical knowledge of Reese-Bucklers rather than granular dystrophy, what's the key difference between them when you look at them clinically?
And Lucy's also got a good point here in the chat. You can see she's found something good in Eagle, because we know this is a recurrence.
It is, yeah.
Lucy,
Yeah.
do you want to speak to what you found?
Yeah, so our group were confused whether it's granular or Reese-Buckler, but I just read in Eagle that when granular recurs in a graft, it typically accumulates in the anterior stroma beneath the epithelium rather than the original manifestation, which is more in the stroma.
That is exactly true. It does do that. And if you have someone with Reese-Bucklers, what does that cornea look like? Does it look discrete little granular things, or is it more a diffuse thing?
More discrete, like breadcrumbs in a clear soup is what my consultant says.
Or for granular?
Oh, for granular, yeah.
Yeah, and for the other one?
I haven't actually seen Reese-Buckler, but in the photo in Eagle, it's more diffuse looking.
That's right. So here, despite it being anterior, we've got quite diffuse lumps rather than the very uniform distribution of the Reese-Buckler. So for that reason, I would think it would be granular dystrophy recurring in a graft in its typical site. Now, I ask people to look at the native cornea at the side, and often in the native cornea, you can see the deeper stromal deposits, but in this one, sorry, we didn't have that.
That was a good discussion and problem-solving sequence.
Yes.
Yeah, teamwork.
All right, any more questions? Go on to the next one.
Why were there endothelial cells present?
Oh, okay. Were there endothelial cells present? Let's go back to the slide.
As we first of all started off in our group discussing, was this full thickness cornea or not?
Yeah. So there are endothelial cells present, but they're a bit attenuated. There's one here and one here and one here and one here.
So just to confirm, they are present.
They are present, just
Very
less than normal. Yeah.
Okay.
Okay. Let's move on to the next one, and I will pop people. Oh, sorry, I forgot to share the screen there. I'll just share the screen and show you. I should be given a D for Zoom today. Right, let's go back here. All right, yes, here they are. This is the nuclei of them here. They're not very distinct.
But they're present.
But they're present, yeah.
So that's part of identifying normal before you dive into the abnormal.
Yeah. Okay, let's stop sharing. Let's put you in breakout rooms again. Off we go. Next slide. Yeah. Okay, how was that one?
That was easier than the first one.
A little more straightforward, we think.
Good.
Oh, right.
All right, I think we're all back now. So I am recording.
Okay.
Do you want to do that one, Amanda?
Sure, I'll do this one. I'm just bringing up the right screen. These things, like they come up a lot better on a special stain, easier to show.
Yeah. We
Anyway,
haven't talked about special stains, but what special stain in particular were you thinking of, Amanda?
I really like PASs for my membranes.
That's right. So all my corneas normally come with a PAS standard.
Yes, I'm trying to get that done, but it's very hard to get that to stick anyway. Okay, so we have corneal button, looks like it's been bisected. There is artifact on the slide. This is mounting media, which is the cloud shape, and the black dots are dust, so it's uncleaned. This little divot here is a fold, and this cleft and dehiscence here are artifactual. So got the artifacts out of the way. I'm looking at either ends. I don't see any evidence of scar, so I think this is the native cornea, the primary. I'm going to start from the anterior and work my way down to posterior in a logical manner. And I can see at this power, I think it's a full thickness penetrating keratoplasty. So it's a full thickness, not just a partial thickness cornea. So I'm looking at the epithelium. It looks like normal thickness, no inflammation. And I do see some clefts between the base of the basal epithelial cells and the Bowman's membrane. So I'm just bearing this in mind. Could this be subepithelial edema leading to, like, it might be developing into a bullous keratopathy type pattern? Bowman's membrane itself looks fairly unremarkable. The corneal stroma looks about it's still got clefts, so I'd say no corneal edema. There's no inflammatory infiltrate, no deposits. Was in the previous case. Coming down to Dismays membrane. Dismays looks really wavy, looks like sort of corrugated iron, something like that. So it would make me want to go and look closely at Dismays membrane. And I'm looking here at this surface, the posterior surface. I'm coming across these little bumps, like little mushroom excrescences that are occurring on the posterior surface of Dismays, and endothelial cells are still present, but somewhat sparse. So this lumpy look, they look like guttata to me, and they're in the right place for guttata. So I'm thinking about Fuchs dystrophy in this location. And if it is Fuchs, sometimes it's associated with corneal edema, but I don't think that we have evidence of that here.
Close the door. You have 1 minute.
And there we go. How about some bullous keratopathy happening here? So I would say Fuchs endothelial dystrophy, and the special stain that I'd like to do is PAS stain, which stains up the basement membranes really nice dark pink color, and I'd be able to see these little excrescences better, especially if there had been what do you call it when you get regrowth, more Dismays filling in between the guttata.
Okay.
Yeah, I think this is a well advanced case, so the mushrooms have kind of become humps.
Incorporated.
Yeah. So there's some other special investigations that I would like to suggest that the candidates might like to think about in this case. Just like with the epithelial stromal dystrophies, we now have a good genetic basis for Fuchs endothelial dystrophy. And admittedly, it only occurs late in life and is easily treated. But some people might want to know whether or not their children were at risk of it, particularly if they'd got an early onset version. So can people remember what the genes are that are involved with Fuchs endothelial dystrophy and whether what the inheritance is? Yeah, that's good. COL8A2 for early onset. Oh, ZEB1 for late. So clearly you guys are well up with it. I hadn't heard of ZEB1. I'd heard of a different one. I've definitely heard of COL8A2. TCF4, is that a gene that's associated with Fuchs? Yeah, and yeah, okay, and yes, it's usually autosomal dominant with incomplete penetrance. So a person can carry the gene and it doesn't really show the age of onset, is my understanding. Is that right?
Yeah.
Yeah, so autosomal dominant with different degrees of penetrance. You guys are all over the genetics of this. That's fantastic. I think that's all I had to add for that one. Is the genes in the corneal dystrophies are probably going to be a more commonly asked question as we improve our genetic diagnoses. Have you ever had anyone with Fuchs who've wanted to have their family tested? No. Okay. Good. Let's carry on. Let's do the next one. I will put everyone into random groups again. Off we go. So welcome back, everyone. How was that? A bit harder?
Little bit harder.
Okay, we are all back now and we are recording. So what was the big difficulty people had with that cornea?
Well, I think there were some distractors in there, quite possibly.
Okay, what did you think might be distractors, Amanda?
Well, some of those epithelial cells were really clear looking, like on the surface, like really
They
clear.
were a bit clear looking, weren't they? Should we,
Were they the focus of this corneal?
no, they weren't. No. Let's share screen. It's my turn, isn't it? Okay.
There's a Cura Cloud lesson on this, is what I explained too.
Great. I will share screen. Okay, and I will just find the actual thing. Okay, so here we go. It's a cornea. We can see that at low power that something's happening predominantly towards the center of the cornea. When we go a bit closer, we can see that there's a disturbance in the epithelial clefting, particularly towards the center of the cornea. So let's have a look at the peripheral bit here.
Stromal clefting, you mean?
Stromal clefting, sorry. So at the periphery here, there's stromal clefting, and the epithelium, Bowman's, Dismays, it's got a ton of endothelial cells. This was a young person. Are these the pale cells you were talking about?
Yes, so this was quite distracting.
Okay, why? So what were the theories that were being put about that?
Cysts, intraepithelial cysts.
Okay, so these cells have got clear cytoplasm, which can occur for a variety of reasons. It's unlikely to be lipid, but it could well be glycogen, because glycogen accumulates quite often in epithelial cells. So I didn't think that these were, I mean, they're slightly unusual, but yeah, I wasn't focused on them. I thought they might have just been kind of unusual glycogenated cells for some reason. So the cornea is looking okay through here, and then it gets abnormal in the middle, and then over the other side, over the other side again, it starts to look fairly normal again.
Is that a epithelial? Yeah, that thing. Is that the pathology?
No, this is a tear. So this is an artifact. It's just a little tear. Yep. The other thing that we notice is it's quite wide at the center and it's quite narrow in the middle. So knowing that we've got a pathology that is concentrated in the middle and there is some change in corneal thickness, I start thinking about keratoconus. So with keratoconus, there are a variety of changes. Oh, there's some more of those clear cells with glycogen in them. Here we can see Bowman's membrane stops abruptly and then restarts again. So this is an area of previous ulceration, and we've got this fibrous scar. And as we look down underneath here, the scar actually goes quite deep, so probably several episodes of scarring, because the corneal collagen here, which will be nice and linear, is no longer linear. It's all kind of all hashed about. So we've got scrambled collagen there, and forming quite a deep scar. Oh, here's another artifact.
That it wasn't herpes. Like herpes can make scars.
It can make scars. So herpes can make scars and can give ulceration, and sometimes the grow back can be that. So if we're thinking of herpes zoster, I would look along here at the basement membrane for little granulomas if it was healed over and not acute. Because if it was acute, we wouldn't probably, so if it was chronic, we probably wouldn't see the intraepithelial inclusions here.
Can you see inflammation? Are those cells inflammatory cells?
No, there's no inflammation at all. If this is a well-healed scar. I was just trying to remember whether or not, I guess you would with a herpetic cornea still have a few lymphocytes hanging about. Yeah.
Oh, no inflammation, non-inflammatory scar. Okay.
Yep. With some thickened and thinned epithelium and a central area of scarring, and maybe some changes in thickness. And we've got another area of scarring over here, so we can now recognize it as Bowman's ends. And this scar goes down to about here, where we've had the linear collagen preserved here, and then this quite deep area of scarring through here, and again, variations in thickness. I know some people were discussing whether or not this was a basement membrane dystrophy, but with the basement membranes intact, it's really quite okay. You know, we aren't getting little curls of it going up anywhere. I think herpes is a really, really good differential diagnosis for this. This is something that's had a chronic ulcerative and deep stromal scarring kind of condition happen to it. So knowing that I'm seeing deep stromal scarring, team, what is the differential diagnosis that you would generate?
Herpes.
Herpes, yep.
Keratoconus.
Yep.
A previous keratitis, like a
Previous keratitis from no other particular source. Yep. Yep. So how would I report this? I would report this as a cornea showing previous ulceration and scarring with central thinning, suggestive of keratoconus. But I don't think that I would be able to completely exclude the other differential diagnoses on this. What stains would I do? Well, I'd always do a PAS stain. If I did a herpes stain, because we can do immunohistochemistry for herpes, and that was still in the differential diagnosis, I would definitely do that.
And we've got some good questions. Chris has asked about a Dismays flap. There's a little curl that I can see in Dismays just in that field.
Oh, sorry. Oh, yeah. In here, there's a curl in Dismays. Yeah. Oh, there. I didn't spot that actually. But yes, there we go. We've got a Dismays break. That would be entirely consistent with keratoconus, wouldn't it?
What's that big line there going across the stroma, Diane?
This is called a score, and this is where the knife that's been cutting it has got a tiny, tiny little chip off its edge and has not cut uniformly.
So an artifact.
Artifact, yeah.
Yes.
Yeah, it's worth nipping along Dismays for those when you've got more time. So you might, if you were asked about the inheritance of keratoconus, what would you say about it?
Sporadic.
Mostly sporadic, but there is an association with
allergic eye disease
and Down syndrome.
Yeah.
And anything else?
Floppy eyelid syndrome.
Floppy eyelid syndrome.
Yeah, and Leber congenital amaurosis as well.
Okay. Is it ever autosomal dominant? Does it ever occur in families?
What does it say? Some cases.
Some cases it can occur in families, yeah. But there's no, I think there's no like, oh, it's this gene that's been done it yet. So here we go, this is the inheritance.
Polygenic, potentiated by the environment. That's always a good answer, isn't it?
Yeah, polygenic, potentiated by the environment. Hello, diabetes, hypertension, yeah.
Good standard answer for the difficult things that are not monogenic.
Have some other things. Ehlers-Danlos syndrome, yeah, that's right.
Yeah, so yeah. It could be localized like eye disease, like the allergic conjunctivitis, or systemic collagen disease, like Marfan, osteogenesis imperfecta, and Albert's, all these ones.
Good. So, Juliana, are there increased numbers of keratocytes? Yes. So, in the areas of scarring, you do get increased numbers of keratocytes. There were increased numbers there. Good. Okay, so there, I think that was the end of our corneas. If you want to see, is it the end of the corneas? I think it might. If you want to see more corneas, then if you, I'll just share my screen again, then if you go back to here.
Oh, yes, the leads.
The leads thing here, right? Go, if you click here on leads, this is a brilliant resource. right? Ocular pathology has lots of different things in it, but the cornea section in particular is really good, and you'll see our corneas come from there, and it has got lots of great corneas in it. There's a lovely one like this one here. And if you go there, you get the diagnosis as well, but you can challenge yourselves not to look at the diagnosis and try and work out what kind of stromal dystrophy this is before looking at the diagnosis.
Yeah, it's always best to do it that way. Challenge yourself first.
Yeah.
Write down some possibilities and then look at the answer. You'll
This is-
remember it a lot better.
This is why we've been teaching you this way. Okay, I think it's time for a stop recording and pause now, isn't it?
Stretch. Yep.
Stretch. So we'll take
Stand
5
up.
minutes to do that,
Yes. Stand up.
and then we'll all get back to looking at things. So that takes it, yeah, just we'll say 1:45.
Okay, good.
1:45.
And Nick wanted me to let you know she's tied up at work, so she's not going to, Nicola Glassard, she's not going to be around for her presentation.
Okay.
She said she emailed it through, so it might have come through to one of you.
Okay.
For what that's worth. Anyway, she says, sorry.
Okay.
She can't be here.
Stop
Good.
recording for now.
We'll, anyway, 5-minute break, and then we'll think about this next slide. Good.
Stop recording.
Stop recording. Good idea. And stop recording. Thank you for that
Okay.
reminder.